All right, everybody, welcome and good afternoon or good morning, depending on where you are in the world. Thank you for joining our EIM Research Learning Collaborative activity today. And really pleased to have three fantastic speakers here today. Let me share my screen here. So the focus of today's RLC presentation is really focused on early careers or student opportunities. And so today we've titled it EIM-Related Research Projects for Graduate Students. And it might not be just for graduate students, but master's students, doctoral students, postdocs, early career investigators. But we have three investigators on today that have done research at investigations in earlier parts of their career related to EIM. And I thought it'd be wonderful to bring them together to share their experiences so other people in similar situations maybe could ask questions and learn from their experiences. So like with all our presentations, I start with a brief introduction on what exercise medicine is. And really it's a global initiative where we're striving to make physical activity assessment and promotion a standard in healthcare and connect healthcare and patients with evidence-based physical activity resources for people everywhere of all abilities. Within exercise medicine, really have these three main components here in blue: routine physical activity assessment and screening, brief advice, counseling, and/or a physical activity prescription, and then referring patient to physical activity resources. Those 3 points really occur in the healthcare setting. And then the fourth point is now we connect the patient and try and engage them in physical activity programs and resources, our 3 Ps, our programs, places, and professionals. Within that, we developed the EIM Research Learning Collaborative. And this really stemmed from an initiative saying we just don't have enough research out there about how EIM works and the benefits it is integrating physical activity into healthcare system. So we really wanted to bring together you all and many other people. We have over 300 people on our listserv now to learn from each other, share and apply best practices, and really increase the capacity of our scientists to make a stronger case for the evidence of integrating physical activity as a standard in clinical care. And we're trying to do this obviously through presentations, panels, mentoring activities, grant writing. We're working through many of these things as we go along. So today, this is, like I mentioned, this is a part of our early career developmental series. 1 out of every 3 or 4 sessions, we want to target early career professionals. We did our first one in December 20th, where we had small group mentoring sessions and breakouts with some experts in the area. Today, our goal is really to provide that exposure to the 3 individuals who will speak on different EIM-related research topics. I have future ideas there. If you all have some need, something you'd like to see in the future, please do let me know, either through a chat, private chat, or an email. We'd love to try and meet your needs and do everything we can to help you out. So without further ado, we have 3 panelists today. The first will be Francia Portacio, who's an associate director at the University of Pennsylvania, working in the School of Medicine. Second up will be Mariana Wingood, who's a physical therapist working on her PhD at the University of Vermont. And last, we have Sergio Calonge from our EIM in Spain team, who's working there in various different roles. So without further ado, let me stop sharing my screen. And Ms. Portacio, I'm going to allow you to share your screen and take over, please.
Wonderful. Can everyone see am I sharing my screen? All right, good. Great. Well, hello, everyone. Again, my name is Francia Portacio, and I'm going to share a little bit about my capstone experience as a master's student at the University of Miami Miller School of Medicine. So my project looked at the implementation of a referral scheme to text messaging programs for physical activity and healthy eating in underserved Hispanics. So it all started thanks to my advisor who connected me to St. John Bosco Clinic. He was at the time working with several free clinics in the area, and I was specifically interested in learning more about how free clinics work and exploring ways to link underserved Hispanic populations to health behavior programs. In meeting with the clinic director, she shared with me the opportunity to partner with CareMessage. CareMessage is a nonprofit patient engagement platform that offers text messaging programs and different other technology opportunities to free clinics around the nation. So I reached out to CareMessage, and as part of their philanthropic efforts, they offered to give us 2 text messaging programs as a free trial. So I consulted with my advisor and went back to the director and proposed to her the idea of a healthcare provider referral scheme. She loved it, and as a matter of fact, said, "Oh, our healthcare providers will refer a lot of our patient population." So I said, "Great, let's test it out." So that led to this pilot study. The study aimed to examine the implementation of a healthcare provider referral scheme linking Hispanic patients to nutrition and physical activity text messaging programs. Originally, the plan was to also examine the effectiveness of the text messaging programs on patient health behaviors. However, as I will explain in the next few slides, we had to shift our focus to better understand the barriers that were faced in implementing the referrals. So first, let's look at the healthcare providers' involvement in the study. Before the referral period, the medical director was asked to review the content of the text messaging programs to make sure it was culturally appropriate for our target population. Then I met with each healthcare provider and offered them training to go over the protocols, explain to them more about the text messaging programs, and help them be prepared for when we start the referral period. I also downloaded a Word document onto their desktop with a referral script for consistency. Then during the 8-week referral period, the healthcare providers were asked to physically hand a referral card to Hispanic, Spanish-speaking adults whom they deemed eligible for the text messaging programs. They then had to copy and paste the script into the patient's EHR, electronic health record, and then hand the patient with a clinic consent form that had to be submitted on the way out at checkout. Now, during this referral period, we actually saw how low the referral rates were. So that's when we had to then focus more on understanding what the barriers were. So I then conducted in-depth semi-structured interviews with each healthcare provider. Now I'll discuss more about what we learned through the interviews, but next I'd like to explain a little bit about the patient's involvement in the study. So 291 patients were seen during the referral period. Out of that, only 26 patients were referred, so just about 9% of the total patients seen. Only 17 were actually eligible patients. Now, out of the 17, only 1 self-initiated. So that meant they actually sent in the keyword to the message as indicated in the referral card. You can see on the bottom right. The rest of the eligible patients, which were 16, received a follow-up call by an intermediary clinic intern. From those calls, 11 agreed to enroll, which was about 42% of the referred patients. So all in all, we had 12 patients enroll in the text messaging programs, which I verbally consented, added onto CareMessage so that they can start receiving the 16-week text messaging program with 3 text messages per week, all in Spanish. I then did a pre and post assessment with each participant. Now, understanding that we had a low reach is what shifted us to really understand more what the barriers that the healthcare providers were facing. So out of these interviews, we learned 4 overarching themes. Number 1, time, how long the overall referral process took for the providers. Number 2, the lack of communication between the administrators and the providers prior to implementation. Number 3, lack of resources. So the need for additional staff support in answering questions about the text messaging program and the overall process to the patients. And number 4, technology, specifically the inefficient method of documenting the referrals on the electronic health record. So all in all, the main takeaways that we got from the study was buy-in, needing the healthcare providers to buy in to the referral, making sure that they then adapted, therefore leading to a higher reach. Having a more efficient and streamlined referral process, therefore making it quick and easy for the healthcare provider. Having additional support to assist patients, and most importantly, having an intermediary to conduct a follow-up, which, as you saw, was able to reach a lot more participants into the study. So I want to thank St. Juan Bosco Clinic for the opportunity, Care Message for partnering with us, and also a quick plug. I welcome you all to check out this work that was recently published in the Translational Journal of the American College of Sports Medicine. Overall, this was a great learning experience for me, and I look forward to answering some of your questions. Thank you.
All right, thank you, Francia. And I forgot to mention to everyone, the plan today, I should have done this, is to have brief presentations from each of our three guests, and then have a long period of question and answer to get into it. So right now, we're just giving you a little taste of the type of work they did, and then we can really dive into the different factors and experiences that along the way. So next up, Mariana, please.
All right, let me share my screen. So hello, everyone. My name is Mariana Wingood, and I will be talking to you about my PhD dissertation that is really themed around EIM. So to start, I wanted to give you a little bit of a background. I graduated from physical therapy school in 2012, and I practiced as a clinician for 6 years prior to deciding to pursue my PhD. And the reason for my career in healthcare and my decision to pursue a PhD are really due to my wonderful grandparents, particularly the lady on the left here who raised me for the first 4 years of my life. And I entered the healthcare field because I never got a chance to directly thank her. So I figured by pursuing a career in healthcare, I could indirectly thank all the grandparents and older adults for all that they have done. However, quickly learned within clinical care that there's no evidence-based or limited evidence-based practice, and that primary prevention is really lacking in geriatric physical therapy. So you may be wondering why I decided to focus on physical activity prescription among physical therapists. The reason is that the World Confederation of Physical Therapy and the American Physical Therapy Associations, as well as the patients, expect physical therapists to provide physical activity promotion and prescriptions. However, according to research done all around the world, it's been identified that they're not really doing what is expected. When you examine that further, you identify that PTs have knowledge about their role of prescribing physical activity. They report being confident in their knowledge related to physical activity, but when tested, they don't really seem to have the knowledge. And that may be one reason why they're not prescribing regular physical activity within physical therapy practice. So I decided to look at that a little more details, and I also decided to examine it within the US because most of the research has been done outside of the US. So for my dissertation, I plan to explore the physical therapist's physical activity prescription characteristics, as well as examine factors that impact physical activity prescription, and to validate a tool that helps with prescribing physical activity to adults 50 years and older. So my first study that was part of this overarching aim was an ethnographic study. And an ethnographic study really was to examine the PA prescription among physical therapists, as well as the factors that impact this. You may be wondering what an ethnographic study is. An ethnographic study is really a qualitative study where you perform observations as well as interviews. So I did 16 hours of observations, and then I also examined the physical therapist's knowledge regarding physical activity, as well as their attitude, beliefs, practice habits, and prescription barriers. And that was followed by qualitative interviews. The results of the ethnographic study really identified that physical therapists have the intention and awareness, for the most part, also have the knowledge related to physical activity prescription. However, there are contextual factors that really impact their decision to prescribe physical activity. And that then it results in physical therapists really either focusing on a biomedical model, meaning they prioritize the patient's impairments and pathology, or really focusing on a physical activity, well-being, health prevention within their clinical practice. For my second study, I did a validation study, and the reason for this is that both the preliminary data and an ethnographic study identified that one of the reasons physical therapists are not prescribing physical activity is that they do not have the necessary tools needed to provide individualized physical activity prescriptions. So one of the missing tools is really a multifactorial physical activity barrier assessment tool for patients 50 years and older. Therefore, I spent the last 3 years developing a new tool, and the tool is called the Inventory of Physical Activity Barriers. And I'm excited to announce that the initial development and validation was just been accepted to the Journal of Geriatric Physical Therapy. And for my PhD dissertation, I did a large validation study, which had an N of 503. For the validation study, there was really two parts. There was a cross-sectional study that really looked at the scale's validity and reliability. And I also did a crossover study design that looked at the ability to use electronic and pen and paper formats interchangeably. I will not go into the specific analysis of this because I could talk about that for hours. Just in summary, I found via exploratory and confirmatory factor analysis that there was an 8-factor solution, meaning the barriers within the tools could be classified into environmental, physical health, physical activity related motivation, emotional health, external factors, skills, social, and energy. It was identified that the tool is reliable and valid and that it can differentiate between those individuals who meet the recommended levels and those who do not. And here's just an image of the 27 item final tool. And just to put it into perspective, I started with 178 items. So to go down to 27 items was quite the journey. So for my last study, I aim to explore the implementation of potential innovative solutions to address physical activity prescription barriers, such as the Inventory of Physical Activity Barriers, as well as a physical activity toolkit that I'm currently developing. To do this, I did a focus group, and for the focus group, I had them fill out the same questionnaires regarding knowledge, attitudes, beliefs, and barriers to prescribing physical activity. Then I ran 4 focus groups, which had an N of 26 total, and afterwards I assessed quantitatively the participants' perception about the IPAB, or the Inventory of Physical Activity Barriers, acceptability, appropriateness, and feasibility. In general, the results identified that PTs agree that they know it is part of their role and that they should be doing it, but many do not feel confident of addressing the lack of physical activity, which is shown here in the first quote. They also felt that having more detailed tools, such as a physical activity toolkit, could help address some of that lack of confidence shown throughout these quotes. And then really their last piece was the value of interprofessionalism within physical activity prescription and promotion, and how really it needs to be a full approach, starting with primary care and public health as well. So my next step is to create a physical activity algorithm, which will use the physical activity barrier tool that I have developed to create solutions on what to do with the barriers. And then I plan on creating a toolkit as well as an app that incorporates all of these tools that are available, followed with some implementation study designs. So this is really the 360-degree view of my research, and I look forward to further discussing it. And for now, I want to thank you on behalf of all of my office staff for listening. And I'll hand it back to you, Mark.
Fantastic. Thank you, Mariana, for that very quick overview of some fantastic work there. Sergio, let's go to you and learn about your work that you've done over the last little while in Spain.
Okay, thank you. Everybody can see my yeah, that's right. Hello, everybody. My name is Sergio Calonge. First of all, I would like to thank to the Exercises Medicine Initiative the opportunity to present my thesis experience in this webinar. Considering the different agents and resources of the Exercises Medicine Initiative and the following all dimensions of the socio-ecologic approach, I start my PhD thesis with this question. Is the national healthcare system prepared to implement a cost-effectiveness strategy to promote physical activity and prescribed exercise by the primary healthcare system according to the philosophy of exercises medicine? And the aim, or the main aim of my PhD thesis was to analyze the feasibility of physical activity on prescription implementation at primary healthcare center in the region of Madrid, Spain. To resolve the main aim, we performed different studies. The first one for analyzing the inclusion of physical activity and exercise as a preventive and treatment resources for chronic diseases in the bachelor syllabus of medicine, sports science, and nursing of Spanish University. And the results were that the Bachelor of Sports Science, Nursing, and Medicine only had 17, 5, and 3% of the total credit, respectively, for their graduate students. On the other hand, we thought that as important to apply a successful physical activity on prescription treatment should be to know if the patient could be able to follow it. In this sense, we did a review of the scientific literature about exercise adherence. According to the WHO multidimensional adherence model, the results were that primary health care team and system and therapy-related factors were not as considered as condition and therapy-related factors and mainly socioeconomic related factors. In a secondary study, trying to reuse data of another study to predict exercise adherence, we propose an adherence model to predict 75% of adherent exercise training program of chronic kidney chronic patients. The regression logistic model showed that the increase of 1 unit of actual side effects symptom problems produced 7.8% of non-adherence. Furthermore, the increase of 1 unit of emotional well-being produced 4.6 of adherence. And the increase of 1 unit of self-perceived state anxiety produced 12.2% of adherence. And finally, 1 unit, the increase of 11.8 of non-adherence. Then, in a new study, we tried to analyze in depth attitude, self-perception, barriers, and facilitators of nurses and physicians towards the implementation of exercise prescription at Madrid primary healthcare settings. First of all, we did a semi-structured interview guided by an expert psychologist to 5 randomized primary healthcare nurses and 5 physicians in 2 sessions of 2 hours each. All transcriptions were peer-reviewed using a qualitative content analysis method, and discrepancy in the categories found were compared between the 2 reviewers and decided by 5 experts in their field-round session to design the question of a Google Form questionnaire. In study 5, we validate by the group of experts the choice modeling questionnaire to analyze the feasibility of implementing physical activity on prescription at primary healthcare setting, as you can see in the screen. Then, finally, the validate questionnaire were sent to all GPS and nurses of primary healthcare system of the region of Madrid, and 258 GPAs and 253 nurses responded to the questionnaire. The results were shown according to the physical activity barrier and primary healthcare staff categorized by professional category, and the collaboration with a local physical activity on prescription resources categorized by the 7 primary healthcare system areas of the region of Madrid. For physical activity on prescription varied by Madrid primary healthcare system, there were significant differences between nurses and GPS in lack of Spain and consultative barriers to implement physical activity on prescription at primary healthcare settings. Besides, both primary healthcare professionals identified staff and patient awareness as well lack consult time as the most necessary barriers to implement physical activity on prescription in primary healthcare setting, such as you can see inside of the red square in the slide. In the collaboration with local physical activity on prescription, we found a positive trend for nurses in the collaboration with local sports center and private gyms when the professional position was less steady in contrast that shown by GPX. Finally, for contributing design of a patient and agnostic tool at primary healthcare center, we measure objectively by accelerometer and subjectively by two questionnaires, exercises medicine and international physical activity questionnaire, short version in Portuguese, in two pilot studies with a reduced sample of 2 people and 4 subjects independently. The sedentary and physical activity levels in 7 days. In the first pilot study, we can see on the top of the figures the differences between physical activity and sedentary level for 8 subjects, based on the position and methodology process of the accelerometer, used to register 8 subjects. In the second pilot study, using accelerometer and the other 2 questionnaires before mentioned, we can see the table in the highest differences between both methods for physical activity and especially sedentary levels. With this careful result, perhaps an alternative for physical activity vital sign could be used between measure physical fitness as a vital sign for patients in healthcare settings. To conclude this brief presentation, as practical conclusion and future research line, I would like to say that physical activity knowledge should be reinforced in the syllabus of health professionals. New qualitative research studies should be done to analyze the self-perception of patient healthcare system managers, policymakers, among others, under the social ecologic theory approach. A pilot study of exercises medicine implementation according to the specific context and the current scientific evidence should be done. In this sense, this PhD thesis could be used at the first step to design a future cost-effective policy strategy to implement patient health and healthcare system sustainability according to exercises medicine initiative. That's all. I would like to finish thanking to my INFINE research group and the research colleagues who have participated in this project. Thank you very much for your attention.
Thank you so much, Sergio. That was, wow, that was a lot of work you did there. That was fantastic. Thank you for sharing that with us. So I'm going to get things kicked off with a couple of questions, and then we can bring in the audience for your questions. So for all 3 of our panelists, my first question is, what really motivated you to get into working specifically integrating physical activity into health settings? You know, Francia, would you like to start with?
Sure. So, you know, I think for me specifically, I was very interested in helping connect hard to reach population, which are the low income, medically underserved, undocumented individuals, to resources that are easily accessible, as in text messaging programs, that would offer them the opportunity to learn about physical activity, to understand that movement is an important part of a healthy and active lifestyle, to understand that, you know, not having a gym membership is okay. You can still live a healthy, active lifestyle. So just wanting to empower and help educate and motivate these individuals to physical activity opportunities and learn ways that they can do it at home, learn ways that they can do it outside of the gym. So that was my motivation as part of my study.
Fantastic. And Mariana, what motivated you specifically to get involved with integrating physical activity into physical therapy settings?
Yeah, I think the thing that really got me excited is the fact that, or the reason I started this is the fact that within our scope of practice of physical therapy, it says health promotion and physical activity prescription everywhere, and that physical therapists should be leading the movement of prescribing physical activity in healthcare, yet they're not doing it. And I really wanted to learn more about why they're not doing it and what solutions can we develop for clinicians to overcome the barriers that they're facing on day-to-day practice. Because there's a lot of things healthcare providers are supposed to do, and it can get really overwhelming. So I want to provide tools that can overcome that.
And Sergio, what about you? What was your impetus to getting started with this line of research?
Yeah, I am a sports scientist, and I know that all the benefits of exercise provoke in human body. Furthermore, I know that it could be offer sustainability for the future of the public primary healthcare system, especially in Spain and Europe in the future. Physical activity on prescription should be one of the major challenges for worldwide public health, in my opinion.
Thank you. So Mariana, I'll start with you next time, or this next question is what was like some of the most important lessons you learned through this research, and not necessarily you know, the data you collected or the results of the research, but the process itself. You know, what are the things that you learned that you didn't know when you started, and you might go back and give yourself some advice if you could?
Yeah, I was thinking about this the other day as I'm preparing to defend my dissertation in 3 weeks. And I think my number one issue, or my number one thing that I slightly regret, is that I decided to do a PhD in 3 years, which is a bit of a short period of time to really get a lot of publications out there. And I also spent the first really year to 2 years, I wrote a book chapter and 3 monographs, which are great and really valuable for many individuals. But I wish I spent that time collecting more pilot data and doing smaller projects.
Excellent. And I noticed just you mentioned that once we get your work published, we'll get it onto our EIM reference list and circulate to everyone. It's still in progress, correct?
Correct. Yeah. I'm hoping to submit my dissertation today to my committee, and after they approve it, I will prepare them for publications. I have 4 manuscripts within my dissertation that will be prepared for publication soon.
Excellent.
And then other articles that are currently in review.
Fantastic. Sergio, what if you could go back at the beginning of your PhD experience, what were some of the most important lessons you'd tell your former you and things to learn from along the way?
Yeah, one of the most important lessons I learned was the difficulties to publish the result of the studies of my research project, especially for English language. For me, it's a big handicap. Besides, it's too slow, the peer review process in some review journals. Furthermore, we spend a lot of time with the ethical committee's approvals and the legal aspect to perform or qualitative research at primary healthcare settings.
Well, let me dive into it. You brought up some great points. So first of all, you know, and we do have some folks here and that will view this that are from other countries. What were some of the things? How did you overcome the language barrier? I mean, you've done a fantastic job translating your presentation. Really appreciate all that extra work. How did you get this prepared in English for submission to scientific journals?
Sorry, Mark, I can't understand well your question. Could you repeat, please?
Yes, what did you do to help translate to English for publication? How did you do that?
Yeah, my supervisor and the director of my thesis helped me to translate some of the researches and papers, but she's not her. It's really difficult to publish in a good impact factor journals.
Yeah, no, I can imagine how difficult it was. So congratulations to you, Sergio. If you want, put a link to the article in the chat so other people can have access to your work.
Okay, now.
Francia, the question to you again, as to repeat, is what was some of the most important lessons you learned through this whole research process?
So as a master's student who was new to research, I learned that in research, you have to be flexible, you have to be nimble and willing to shift gears, just because, I guess, because of the nature of research and the way it unfolds and develops. So for me, that was a great learning experience. Just getting involved with research, learning about mixed methods approach, quantitative and qualitative data, having good advisors, good mentorship, people that you can learn from, ask questions that help guide you. For me, what was key in this research project. So that's what I learned.
Fantastic, thank you. No, I have one final question for the panel, and then we'll see if any of the attendees want to chime in. Sergio, I will start with you first. My question is, what advice do you have for other graduate students, people who are on this call maybe, looking to do similar research projects in the future? What advice would you give them?
Yeah, we can say several advice, but for example, one of them, the work of my thesis work and similar ones have done our college and in other countries should be a key point to start your research project and adapting to your context. But from my point of view, it's really important to continue the previous ideas of your college, developing the scientific method. Furthermore, for exercises medicine implementation, I consider it necessary to do a specific analysis of all of related factors following a theoretical theory. For example, the WHO 5-dimensional terrain model for adherence, or the social ecologic theory for assessing and designing an individualized implementation for physical activity promotion or exercise prescription.
Yeah, I mean, I couldn't agree more, Sergio. I think finding people that are doing the work and building your project within their work is a great step. And then, as you said, I think using models and frameworks, like you mentioned with the WHO, is very important to give that strong scientific rigor to our work. So excellent advice there. Mariana, to you, what advice would you give? You already mentioned the 3 years, maybe going for 4 years. I see that a lot. We're so eager to graduate. We realize maybe it's not, we would get more if we took our time. What other advice might you give to other master's or graduate students, even postdocs, that are looking to get into this line of work?
Yeah, I will say Sergio kind of took my thunder. I was thinking the same advice of connecting with other researchers who do similar research. And I am also all about using models and theories because I feel like they strengthen your research, but they also kind of provide you a guiding path of where to go. and to make sure that you're comprehensive and don't miss anything. And I guess my last piece of advice that I would give is follow the finer research criteria, which is really looking at feasibility, the impact or importance, the novelty, the relevance of it all, and the how realistic is it, and the ethical piece. But really, that feasibility is so key, because when we start doing research, you're really excited to tackle this gigantic project, but then you many times realize it's a little too much. So just biting off, what is the English saying? Only bite off what you can chew, I think is the English saying they say. But just going small. Small is better, and really concentrating on that quality over going big.
Yeah. So just to clarify, you weren't talking about a feasibility trial, but you were talking about what's feasible for you as an investigator, right?
Correct. Yes. Yeah.
Yeah. Yeah. And I think that's so true for students, PhD students of all. We want to solve the world with our doctoral work sometimes, but it's really just a stepping stone. And I think both you and Sergio really laid it out nicely you could see the clear progression of your work and where you want to go for the next step as a postdoc or an early career faculty member. So that was really brilliant. So Francia, you get the last word here for my questions. What advice would you have? And yours was a master's project. So if there's other master's students out there, what would you say that you tell them?
Yeah, again, I mean, I think Mariana and Sergio really did a great job at this, but I think, again, reaching out to people that are in this field of work that can help guide you and to learn from, and to help you understand what the expectations are and the possible limitations. And so, yeah, I would just say to really tap into the people that can help you, different resources that are available. And that's what helped me get through this project. So.
And I remember, Francia, you telling me that you won top research award for master's students the year you put this through?
Yeah, through our public health program, I was awarded a travel grant and was able to go to Denver and present a poster presentation at the American Public Health Association there. So that was a great opportunity as well to get the word out and share more about the study.
Great. Well, one thing I really like and appreciate from all our panelists is you all are publishing your work. And there's a lot of cases where master's projects, PhD dissertations, once the students graduate, that's it. And the three of you are showing great effort to continue on and getting your knowledge out there so other people can build off of it. So I think that's another great example that you all have shown. So at this point, I'll turn it over and see if there's any questions from anyone on the call. Like to chime in, ask any questions, or even add to the conversation. Laura, Sarah, I know the two of you personally, so I'll pick on you. Any comments or thoughts to our panelists, or anything you'd like to build off of from your experience as educators?
I'll just say that it's great to see that this work is being done, it's being published. I love seeing more and more things, getting published, because I think that's really important to sort of show the advancement in this field. So I just want to congratulate everyone who's kind of heading in that direction, especially to the person who's about to defend her PhD. And I know that's coming down the pipeline, so best of luck. It's really great. Congratulations to all of you.
I'll share that. Hi, I'm Anaja Newsom. I'm from the University of South Florida. I'm a PhD candidate, and I'm looking at the EIM framework from the lens of mental health care, so looking at clinical mental health care. And I found that while I was doing a lot of coursework and research in primary care, I found that the mental health care setting was an area that needed a little bit more investigation. And so I'm using a theoretical framework to understand the barriers of mental health counselors in prescribing physical activity as a part of standard treatment. And so I'm interested if anyone else is kind of looking at mental health care or an area of clinical care that isn't primary care.
Yeah. Well, and Naja, I'll jump in and I actually, a colleague of mine in Dallas, we submitted a grant. They were doing work in 18 primary care clinics where we actually did a quick screener on mental health and as well as the physical activity vital sign. And we were using the two to kind of the algorithm to determine who could be referred or should be referred to physical activity. So I love the idea. Be sure to follow up and maybe in the future we can get you on in one of these sessions talking about the work you're doing, okay?
Thank you. I'd love to be a part.
Good. So you know what I'll do is I'll throw it back to the panelists for last words. And we'll just, any last words or advice you'd like to give, Mariana, Sergio, Francia, about your work. I think it's fantastic that you're getting involved in doing this and leading the way. So.
Yeah, I can start off. And first I'd like to address, Christina, I see your question in the chat. Great question. If I were to redo the study, is there anything I wish I would have done but didn't do? Yeah, I mean, knowing what I know now, the buy-in, it was such an important key factor in the low referral rates. So if I could do this over, I would make sure that the administrators and the healthcare providers would have had more communication prior to implementation of the referral scheme. So making sure that the healthcare providers were on board, that they were all going to adopt the referrals, helping them feel confident in the referrals, helping them make sure that they are willing to refer as many patients as possible to the text messaging program. So that is something I would do differently. Thank you for asking that question. And closing remarks, it was a great learning opportunity for me, getting involved with learning more qualitative data, which is something that I look forward to doing in my next pursuit. And I will be pursuing an EDD in higher education. So I'm shifting a little bit fields, but it's still translatable skills that I look forward to using as I further my education. Thank you.
Great. Sergio, any final thoughts?
To conclude, I would like to repeat that physical activity on prescription should be one of the major challenges for worldwide public health. And I would interdisciplinary approach with nurses, physicians, nutritionists, physiotherapists, and sports science, of course, could do it at healthcare centers.
Well, and Sergio, thank you so much for your efforts today. I know this was a lot of work for you and we really appreciate it. Mariana, last word. You're the one with the upcoming dissertation defense and exciting time for you. What are your final words for us?
Yeah, I think my final word is that if you believe in it, you can do it, is my overall arching thoughts. But I also really want to point out the value, and Sergio kind of touched upon that, but the value of stakeholders. Whatever research you end up doing, get the input from all stakeholders and individuals involved, including those that will be administrating the EIM initiatives, those who will be receiving the EIM initiative. Get to learn from everyone that is involved, because that's only going to strengthen your research and what you do moving forward.
Fantastic. And, you know, we also have several faculty on today and several, you know, and our goal with the Research Learning Collaborative is to really help connect students to faculty, to people doing this work. We'd love to see more of this. Our plans for 2022 is to hold a separate poster session for people doing work in EIM and really bring together all of us to help start connecting people even greater over the next year, to get people like Anaja, to get Francia, to get Sergio, Mariana, more guidance, more assistance. And hopefully now that you're done, Sergio and Mariana, soon you'll be able to give guidance to others in the future. So thank you so much for sharing, and thank you everyone for joining us today. And we'll post this within the week on the website. And with that, I think we'll call a close to today's session.
Thank you so much for the